really amazing to watch what a unified group that we have.
And so what A Twist of Fate has done is put us all together. It's allowed us to pool our data, pool our resources.
The clinic in the United States and A Twist of Fate, we can gather all this information, we can inform patients about their management, and we can provide treatment for those complications.
But with the nonprofit and all the other mothers behind me, I didn't feel alone anymore.
I'm Frank Hanley. I'm the Executive Director of the Betty Irene Moore Children's Heart Center here in Palo Alto, and I'm a pediatric cardiac surgeon by trade. What I would like to do is describe what we actually do in surgery and what we're up against when we see a child with a severe pulmonary artery problem that's creating blockages in the pulmonary artery. And as a result of those blockages, the pressure builds up, and therefore the right ventricle, which is the heart chamber that has to pump through those arteries, must pump at a very, very high pressure. So you may ask, well, who cares? If the blood still gets through to the air sacs and the blood picks up oxygen, who cares whether it's there at high pressure or low pressure, as long as it gets there and the child gets oxygen? Well, the problem with that is the heart chamber is a muscle. It has to squeeze and pump blood. It's only so strong, just like any muscle. And the example I would use would be a weightlifter or a person who doesn't lift weights, who goes to the gym and tries to lift a weight that's too heavy. Your muscle will fail because the muscle isn't strong enough to push that weight. The heart chamber, and in this particular situation, it's the right ventricle, has to squeeze and pump blood through the lungs. If there are blockages in the arteries in the lungs, then that pressure will be extremely high. And when the right ventricle has to pump under such high pressure, it strains the heart muscle. And after months and years of that happening with every single heartbeat, eventually the right ventricle tires out, weakens, and starts to develop heart failure. And ultimately, the problem with this, with pulmonary hypertension, is the heart muscle fails, and that is often the reason why a child or a young adult will start doing very, very poorly. So this idea of the blockage in the high pressure, it's no different than if you turn your garden hose on at home and the water flows through, fine. But if you were to stick your heel on the garden hose or grab the hose and kink it, the water would still flow through, but the pressure would build up because the water has to squirt through the tiny kinked opening. That creates a higher pressure. That's what the right ventricle is seeing when it's having to pump blood through a child with any one of these conditions, whether it's ATS or Williams syndrome or Alagille syndrome or any other of a number of conditions where the arteries, the oak trees going out to those twigs, have blockages in the big branches, either at the main trunk or the first set of branching or the second or third or the fourth set of branching. Blockages at any of those levels will affect the pressure in the right ventricle. So the operation that we've devised over the past 10 years or so is to be able to address those blockages out in the branches of the pulmonary arteries. So to put this into a little bit of a perspective, pediatric heart surgeons are comfortable working on conditions for which they've already been exposed to or for which they've seen during their training. And traditionally, it has always been considered, and this field of pediatric heart surgery is 75 years old. It began back in the late 1940s, early 1950s. Traditionally, the branch pulmonary arteries have sort of been off limits. They've thought to be areas that were so difficult to access surgically, so small, so delicate, that they were sort of off limits. Surgeons didn't go out there. And so in the field, the general feeling among pediatric heart surgeons was these areas are untouchable, they're not operable conditions. We can't really operate on them because we don't have the experience. No one had been done it before, and simply was off limits. When I came into the field and was looking at areas where what are things we do well, what are things we don't do well, this was one of the big areas that I felt we could work on and make significant progress. So over the course of my career, we've developed techniques of being able to work on the pulmonary arteries out into the second and third and fourth order branching points and develop techniques to relieve those blockages. And every time you relieve a blockage in any one of those little branches, you lower the pulmonary artery pressure a little bit. So if we're out in the branches here, now think of the oak tree again, and we're at the fourth level of branching, there may be 20 or 30 of those blood vessels. If 18 of those 20 or 30 have a blockage in it, that's going to create very high pressure in the right ventricle, because that's enough of those small blockages that the pressure starts to build up to a very dangerous level. So one of the techniques that we've developed is to address those blockages, and sometimes we'll do 15, 20, 25, or 30 blood vessels when we do one of these operations. And we'll relieve each one of those blockages individually in both the left lung and the right lung. And ultimately, the more of those blockages that we can address surgically to relieve the blockage, the lower we'll be able to get the pressure in the right ventricle, many times even down to very close to normal levels. Now, another important idea to understand is, well, how do we actually address those blockages? And we have two main techniques that we've developed. One is called the pulmonary plasty or arterioplasty, or patch arterioplasty. And in that situation, we identify a blockage and we can cut across that blockage and then use donated pulmonary artery tissue that has been donated from an individual, not necessarily a child, but an individual who's passed away and donated their tissues to science. And that tissue can be processed. It can be frozen in liquid nitrogen, put in a freezer, and will stay stable for decades. And we have a freezer filled with this material. And when we do one of these operations, we can access that material, thaw it out, and utilize it to enlarge the blocked area of the pulmonary artery with similar human pulmonary artery tissue. That's one of the main techniques that we use to relieve blockages. Depending on the exact configuration of the blockage in the artery, there's another technique that's called a V-plasty, like the letter V, which is sort of a plastic surgery type manipulation of the artery that relieves the blockage without actually having to use any outside donated material. And it's probably not that important to go into the exact details of which blockages we choose to do the patch plasty on and which types of blockage configurations we decide to use the V-plasty technique on, but suffice it to say we'll use those interchangeably in the same patient. So for example, if we do an operation on a child with one of these complex multi-level blockages, like an ATS patient, we may do 25 different procedures on various blockages. We may do 12 patch plasties and 9 V-plasties. And another patient, it may be flipped around, or any combination of those, depending on what the child needs. The whole goal, however, is to relieve as many blockages as possible so the pressure can be reduced in the right ventricle down to a very low level so the heart remains healthy over many, many, many decades. Again, ATS, as you all know, is a very rare condition, unless you're the one who has it, obviously. There are other conditions that I referenced earlier, Williams syndrome, Alagille syndrome, and then even some children with no known syndrome whose arteries just happen to appear like some of these children who have syndromes and specific genetic conditions that identify those syndromes. There are some children who present like this, and for all the world they look like they have one of these syndromes, yet when they check their family history and you check their genetic profile, there isn't something specifically identifiable. And these patients in aggregate are much, much more frequent. So we see these kinds of patients all the time. And over the course of the last, let's say, 10 years, we've operated on hundreds and hundreds of children with these different conditions. Many of them have thickened, fibrous changes in their arteries. They have these kinks and tortuous configurations. They have aneurysms that form, which are bulges in the artery, and they have kinks and blockages that form. So these are exactly what we're dealing with in all of these conditions. So when we see a child with ATS, as rare as that is, all of these techniques that we've developed that we utilize much more commonly are absolutely applicable to a child with ATS. If your child is going to have a procedure and you're going to a team that does this all the time, hopefully it will provide some level of comfort that we're not saying to you, we've never seen this before, we're not sure what's going to happen, because that's not our situation. Now we've got so much experience with these kinds of conditions. When a child has one of these unusual conditions that affects the arteries in the body, and in particular here we're talking about the pulmonary arteries, we don't, and I don't mean this in the callous sense, we don't care, but in the medical sense, we don't care if the child has the condition and even has the genetic marker, as long as they don't have a life-threatening physiologic problem that goes along with it. Now, unfortunately, if you have the genetic condition, it's not uncommon to have one of these sort of complications, if we call it that, or developments that lead to a physiologic problem, but that's when we need to intervene. So we're not going to operate on a child with ATS or any of these other syndromes if we look at their pulmonary artery system, and yeah, maybe the arteries are a little bit thick, but there's no real blockage, there's no aneurysm formation. We measure the pressure in the right ventricle and it's relatively normal or even totally normal. We don't operate on that because there's no reason to. So what we're looking at is the sequelae, or the complications of the condition. And the main one is blockage in the arteries, which, as I mentioned earlier, results in elevated pressure as the right ventricle tries to pump through these small openings. So one of the main indications for operating on these children is elevated pressure in the right ventricle. Another possible reason would be, even without elevated pressure, if at one of the areas of kinking, the artery wall weakened and an aneurysm or a bulge developed, kind of like an old-fashioned bicycle tire where it's worn out and you see a little bubble on the side of the tire. If you just ignore it, well, it gets bigger. A week later it's bigger, and eventually, that's not good for the tire. So whenever we see a bulge in the artery, we always want to watch that very, very carefully. That's an aneurysm. Aneurysms, once they develop, they sort of have a negative feedback loop, in the sense that it gets a little bigger, the wall gets even weaker, that makes it get a little bigger. So there's a progression. We don't want it to progress to the point where that aneurysm becomes so large that it then creates either compression of another vital structure or runs the risk of rupturing. Those are the two things that we're concerned about with aneurysms. So our reasons for operating on children with these conditions is only when they develop these specific sequelae that we know are dangerous for them. So when we refer a child with one of these conditions, and ATS in particular, it's very important before, first of all, deciding whether an operation is necessary, but also deciding, if the operation is necessary, what is the roadmap? What are we actually dealing with specifically? So the way we answer both of those questions is with diagnostic testing ahead of time. The first test that's done is an echocardiogram. And all of these tests are helpful in giving us one piece of the puzzle, but we don't see the entire picture until we get all of the tests. And that's just another way of saying that there's no one single test that gives us all the information we need. So we need to put the pieces together. So the first test that's usually done is an echocardiogram. And the reason that's the first test that's done is because it's easy, it's simple, it's atraumatic or not traumatic for the child because it's relatively non-invasive. It's completely non-invasive. Often, the mom or the dad or the family can be there with the child when the test is being done. There's no puncturing of the skin. It's simply a little jelly on the chest and an ultrasound probe, which is reasonably benign. And if the child's prepared correctly, it's usually not even scary a lot of the time. And so the ultrasound gives us a lot of information. It's the first test that gives us an inkling as to whether there's high pressure in the right ventricle. And the echocardiogram is quite good at identifying the indirect signs of pulmonary hypertension. Now, a picture, an ultrasound picture, is just a picture. It doesn't give us a pressure, but what it gives us is the configuration of the right ventricle. Are the chambers bulging in the wrong direction? Are they thickened? These are all secondary factors that are very important developments that happen when you do have pulmonary hypertension. So the echo tells us right away whether we have a problem or not. If we have a child with one of these syndromes and they have an echocardiogram and the right ventricle looks completely normal, there's no evidence of any kind of pulmonary hypertension, often it may not be necessary to go any further than that, because we already now know is we're not going to find anything that's going to require an operation. That's not an absolute statement, but generally speaking, as a first screening test, that would be very good, and that would put lots of families at ease. Yes, we have this condition, we've identified it genetically, but as of this point, there's nothing bad going on. So sometimes that's all that might need to be done. If the echocardiogram does show something significant, or if there are other reasons why we're concerned, then we would go to another level of testing that gives much more specific information about the pulmonary arteries themselves. And the first test, the next step to go after the echocardiogram would either be a CT scan with an angiogram called a CT angiogram, or an MRI, magnetic resonance imaging test. These are the two tests that are much better than the echocardiogram at showing us a picture of the pulmonary artery and the branches. In other words, another way of wording it is they light up the oak tree. So we can see the trunk really clearly. We can see the branches. We can see the pattern of tortuosity and bending and twisting. We can see if there are kinks and blockages. We can see if there are aneurysm formations. So those tests are also just pictures as well. They give us a very clear idea of the roadmap, but they don't actually measure the pressures. So the final test that we do frequently, and the one that's the most invasive, and this is why we usually hold it to the end and only do it when necessary, is the cardiac catheterization. And this requires the child being fully anesthetized, and it's somewhat invasive in the sense that the leg artery has to be punctured with a relatively large catheter, and that then gets threaded up into the right ventricle, out into the pulmonary arteries, and this is where we can actually measure the exact pressure. So now we know, yes, this child has pulmonary hypertension, but now we know how high the pressure actually is. And the more elevated the pressure, the more concerning it is, the more there's going to be a need for an early intervention. The normal pulmonary artery pressure in someone who's got no condition at all is not anything like it is in your arm. So you go to the doctor, you get your blood pressure taken. The typical number you hear is 120 over 80. You know, the heart beats with a pulsation, so there's a high pressure and a low pressure. 120 over 80 is a normal blood pressure in your arm. But the left ventricle is the ventricle that's pumping to your body, and that's being reflected in the pressure that's measured in the arm. That left ventricle has been designed, you know, over our entire evolution to pump at that pressure. It's normal. It pumps at 120 fine. The right ventricle is the chamber that pumps into the lungs. We can't put a blood pressure cuff on your lung because it's inside, so there's no way to measure the blood pressure in your pulmonary artery the way we can measure the blood pressure in your arm to reflect your systemic blood pressure. The only way to measure that pressure is with a catheter placed in a vein, threaded up into the right ventricle in the pulmonary arteries. Then we can measure the pressure. The normal pressure in the pulmonary arteries and in the right ventricle is not 120. It's not 80. It's not 60. It's not 40. It's 20 to 25. That's what's normal. And the right ventricle has evolved to pump at that pressure. It's not designed to pump at 120. If the right ventricle had to pump at 120, it would fail in a minute because it's just not designed for that. So when these blockages develop gradually, the right ventricle tries to respond by thickening and handling the higher pressure, but it just can't do it very well over long periods of time because it wasn't meant to do that. And this is why the right ventricle is so vulnerable to elevated pressure or pulmonary hypertension. So the reason to do the cardiac catheterization is to find out, okay, we've got these hints from the echo, the MRI, the CT scans, but what is the real pressure? And if we were to do the catheterization, which we frequently would do if there's been a problem identified like this, we would measure the pressure. If the pressure on the right ventricle were 100 or 80 or 70 or 65, that child would need intervention or surgery soon. Because if we don't do it, that right ventricle is literally dying in front of our eyes minute by minute. And sometimes you get to a point where it's irreversible and it would never recover. So surgery would then need to happen relatively soon, meaning within months, not wait and see and let's see how things develop. If at the catheterization, the pressure were 40 or 45 or 50, that's a pressure where it's not normal, it's moderately elevated, and the right ventricle is going to be able to handle that reasonably well, but we need to then follow that child very, very carefully, both to see that the pressure doesn't progress and get higher over time, which it can do, but also to see how well is that right ventricle going to handle that moderate pressure over long periods of time. So even if the pressure didn't go up higher than 45 or 50, and at the time of the first evaluation, the right ventricle looked like it was handling that pressure fine, 3 years later, 5 years later, even if the pressure never went up any further, the right ventricle may start to show signs of strain and failure, and then that would be a clear indication that that child's heart wasn't handling that pressure, and then that would be an indication to go to surgery. A question we often are asked is, if we know there's a family history of a condition like this, or there's some suspicion that my child may have this condition, when should our child be evaluated? It's a very, very important question. And I think the basic answer is, as soon as you know the child has the condition, at least some level of evaluation should occur. The genetic testing, the general systemic testing, and then at the very, very least, an echocardiogram to see whether there are any concerning cardiovascular sequelae or complications related to the condition. That's sort of the baseline that should happen immediately. Then, depending on what that early evaluation tells us, the degree of progression or severity of the condition with relationship to the cardiovascular system will then determine what additional evaluation and testing up this ladder of more and more complex, more invasive tests are necessary, and then that tells us when intervention is needed. And if you wanted to jump right to the sort of biggest question, does my child need to have an operation? The answer to that question can only come after the full evaluation. And sometimes we see children with this condition where we do all of the evaluation and we don't even let the child go home. That child has such a severe problem, they need to have surgery literally before they leave the hospital or leave the institution. There are other children where we do the evaluation and everything looks quite reasonable. We need to continue to get very good follow-up, but intervention, surgery isn't really required at this time. And it may not be required for many, many months or even many, many years in the future, but ongoing evaluation is extremely important. So an important question is, when you find out your child has a condition like ATS or one of these other conditions that are similar, what do we do? The most important thing is to get a complete evaluation by a team that deals with this all the time and understands all of the broad implications that this condition has for your child, whether it's just the cardiovascular system or the musculoskeletal system or any of the other specialized organs of the body that can be affected by some of these connective tissue problems. having a comprehensive evaluation is extremely important. That can only be done by someone who's got broad knowledge of what all of the implications are and has a system in place where you can get all of the evaluation done in an efficient, timely manner where all of the various subspecialists who are involved with the sequelae of these conditions can talk to each other. Because sometimes if there's curvature of the spine and a cardiovascular problem, there may be something that needs to be done for the scoliosis or the curvature of the spine. Is it safe to do that orthopedic procedure before we fix the cardiac condition? Is it better to fix the cardiac condition before the spine condition is fixed? And there are important questions that have to be asked both ways. If the curvature of the spine is so severe that the child's respiratory or breathing function is affected, then that's going to make the cardiac operation and the recovery much more complicated because the heart and the lungs work together. And so there will be situations where the experts would get together and discuss this, and the decisions would be made about the prioritization of what should be done first. And this is why it's so important to have a comprehensive team all together. So a question that often comes up for us is, my child has involvement of this condition in both the left lung and the right lung. And the question that will come up is, are we going to do both lungs at the same time, or are we just going to do the left lung one day and the right lung on at a different procedure? And as we've developed our techniques, it has become quite clear to us that when possible, and when I say when possible, it usually turns out it's the great majority of the time, it's preferable to do both lungs at the same time. And the reason is, despite the fact that that makes the individual operation more complex and longer, it actually ends up being safer for the child. And this is the reason why. First of all, it's one procedure rather than two. And just like if you get on the highway and drive across town to run an errand, you've got some chance of getting in an accident. Not very high, but it's there, as small as it is. But if you do that twice in one day, to go buy milk, come home, rest, and go buy bread, and do it again, you've got twice the risk. So if we do the same kind of operation, even though we're doing one lung and then the next, in a certain way we've doubled the anesthetic risk, with the risk of all of the things that are redundant in doing it two times. So that's a minor issue, but I think a real one. The more important issue is when you do just one lung and not the other lung, what happens is you open up all of the blockages in one lung and none of them in the other lung. So if you come out of surgery under that situation, then when the right ventricle is pumping blood, the blood goes down the path of least resistance. Instead of the blood going 50-50 left lung, right lung, it's going to go 95% into the lung that you just operated on, because that's when you've opened up. And the one that still has blockages, none of the blood is going to go there, or a very, very tiny amount. And you might say, well, that's okay, who cares? The reason that's important is that one of the postoperative effects of these operations is called a reperfusion injury. The lung that's been deprived of blood, or the segments of the lungs that have been deprived of blood due to these severe blockages, once they're opened up, then a lot of extra blood goes into that piece of lung beyond the blockage, and the lung is not prepared for that blood. Even though it's now a normal amount of blood flow, it's way more than that child has ever seen in that segment of lung. In a certain way, the lung doesn't know what to do with that. All of a sudden, there's much more blood going through the lung. It doesn't know how to handle the pressures and the flows, and the lung develops what's called a reperfusion injury. It's like a pneumonia, but without the infection. The lung gets hazy on the X-ray. The air sacs get filled with fluid. When the air sacs get filled with fluid, gas exchange, oxygen exchange doesn't happen normally, and so the lung has to go through a 2, 3, or 4 day period of accommodating to the increased flow as a result of the relief of the blockages, and that's what we call a reperfusion injury. If we do one lung and leave the other one alone, we are then creating a lung perfusion injury in that lung, but that's where all the blood flow is going. But if the oxygen exchange isn't good, we can't rely on the other lung to help out with the oxygen level because there's no blood going there anymore. So in fact, the recovery when you do one lung and leave the other lung alone is actually more difficult and more dangerous than if you do both lungs at the same time and you end up with even blood flow coming right out of the operating room. So for this reason, our evidence and our analyses have told us it's better to do both lungs at the same time. And we do both lungs through a middle sternotomy rather than through a thoracotomy, which is an incision on the side. When you do the incision on the side to work on just one lung, you end up then with two different incisions, and the thoracotomy incisions just in general are more difficult to recover from than a median sternotomy, a single one median sternotomy incision. An important consideration when a child has a very rare or unusual condition, especially a rare or unusual condition that most people are unfamiliar with the treatment options, it's very important to get out there and look at the programs around the country that have a specialized interest in this and an organized approach and team approach to this condition, because that's where you're going to get the best answers. And taking advantage of that resource, even if you ultimately don't get your treatment at that center, you will at least get the appropriate orientation, and you will have most of the questions that you have answered. As great as the internet is and giving us access to incredible amounts of information, many times in my experience when people begin to explore a rare condition like this and they're looking at it through the lens of isolated internet access, it can be more confusing than helpful and often bring up more questions than it answers. And it's important to interact with a team of individuals who deal with this all of the time so you can get your concerns appropriately weighted. There may be something that one mom may be focusing on that she thinks is the most important for whatever reason, but there will be others who have a completely different response to their child's condition. And it's important to talk with an expert who can give you a reasonable weighting of what's important and what isn't. And that's what you're going to get from a team who deals with a condition like this all the time.